Our next presenter, Kathleen, I think all the MPH students know she's not here because she's just had baby Avery. So she's back in Ontario. What is it there now? 2, 3, 4, about 5:30. So hopefully baby Avery is sleeping. We are going to get her on the phone and we will be watching her YouTube presentation, and then she will come live and we will be able to ask her questions about her presentation over the speakerphone. Right. Have we got her yet? No, not yet?
I haven't called.
Okay, so Carmel's just going to call her and we'll get the YouTube presentation started. Well, not quite. It was close.
It might get very loud here in a second then. Hi, Kathleen. Hi. You're breaking up. Can you hear us okay?
I can hear you. I can hear you over the phone, and I can hear you on the webcast.
Awesome. In stereo. Okay, so I'm just going to put your YouTube up. Everyone, Kathleen's here.
Hi, everybody. Tobacco-related illness killing over 37,000 Canadians annually, tobacco use remains the leading cause of preventable death in Canada. Over the last few decades, public health efforts across Canada have seen prevalence rates of smoking among the Canadian population steadily decline, which at first glance appears to be quite an achievement. However, upon closer examination of the data, it sadly becomes apparent that the decline in smoking rates is a highly inequitable one. While smoking rates among the general population have steadfastly declined, rates among populations of low socioeconomic status and who are homeless or vulnerably housed remain much higher. It is well known that people who live in poverty have a shorter life expectancy than that of the general population. This inequitable gap is attributable to adverse health outcomes in relation to the social determinants of health and to modifiable risk factors such as tobacco consumption. From a public health perspective, reducing smoking, particularly among low-income populations, is therefore a key strategy for reducing overall socioeconomic inequalities in health. When it comes to the question of reducing smoking rates in low-income populations, many believe that these individuals have less desire to quit smoking, but this is not the case. The desire to quit is not any less among low-income populations. The success rate of quit attempts for low-income populations, however, is much lower than those of their higher-income counterparts. So why does this disparity exist? Some of the main barriers to successfully quitting smoking in low-income populations include a lack of accessible smoking cessation programs, lack of support to quit from healthcare providers, and a lack of knowledge regarding smoking-related health risks. Smoking cessation interventions such as nicotine replacement therapy, NRT, and taxation on cigarettes can actually widen the existing disparity in smoking rates and successful quit attempts among low-income populations. Since NRT is not covered under the drug plan for individuals on social assistance in Ontario, NRT is not very accessible. With regard to the taxation of cigarettes, there's evidence that shows increasing the tax on cigarettes for a population that continues to smoke only stands to place a heavier financial burden on those with an already restricted income. Fortunately, an initiative exists in Ontario titled the STOP program. It is a province-wide initiative that delivers smoking cessation treatment and counseling support to eligible Ontario smokers who wish to quit. I completed my practicum placement at the Canadian Mental Health Association in Ottawa, CMHA, and worked on a project that piloted veterinary outreach as an engagement tool for smoking cessation in partnership with Ottawa Community Housing, OCH, Community Veterinary Outreach, CVO, and Ottawa Public Health, OPH. Within the context of our pilot project, a veterinary outreach clinic was offered to tenants of an OCH building with a smoking cessation workshop offered during the week following the vet clinic using a modified STOP program. Using their own medical directives, OPH dispensed up to 5 weeks' worth of NRT paid for by CMHA Ottawa to workshop participants. OCH is the largest social housing provider in Ottawa and the second largest in the province of Ontario. They provide almost 15,000 homes for about 32,000 Ottawa residents. In 2014, 92% of all tenant households had annual incomes of less than $35,000. The OCH tenant population is therefore considered low income and vulnerably housed. Motivated by the Smoke-Free Ontario Act, OCH developed a no smoking policy which prohibits smoking on all OCH property, including tenant units. The implementation plan has included communication strategies, staff training, and partnerships with on-site support agencies and organizations that provide smoking cessation services. Our pilot project is an example of one of the initiatives taking place to engage tenants in and provide them with smoking reduction and cessation advice, information, and services. So by now, some of you must be asking, how does veterinary care factor into smoking cessation? CVO conducts veterinary outreach work with homeless and vulnerably housed populations. In their grassroots work, they have found that their clients are much more receptive to teaching regarding their own health after the health of their pet has been addressed, and that pet ownership in this population can be used to open a dialogue around healthy behavior changes. For example, stating, "Did you know that smoking in your apartment where Fido lives puts him at a much higher risk for cancer and early death?" can be utilized as an effective way to engage a client in advice and health teaching regarding smoking cessation. No formal literature exists on the topic, so I conducted a synthesis of related evidence to build a valid argument in favor of veterinary outreach as an engagement tool for smoking cessation. Pet ownership has been widely linked to a diversity of benefits, all having positive outcomes on health, including decreased incidence of depression and loneliness, stress and anxiety, and increased coping abilities and enhanced feelings of self-worth. Many of these health benefits may allow for the self-agency and confidence required to make the decision to and successfully carry out a quit attempt from smoking. I also sought literature that looked at what having a pet means to homeless and vulnerably housed people. In one study, pets were identified as being an only source of companionship and love. Many studies had similar findings of people placing the needs of their beloved pet before their own. This pet before self concept was expressed by owners who would ensure their pet was fed before themselves and who would forego employment, housing, and health service opportunities if these did not include their pet. The pet before self concept therefore allows one to argue that these high levels of attachment between individuals and their pets can be leveraged as a tool for promoting healthy behavior change, such as quitting or reducing smoking. Many studies investigating pet ownership in homeless and unstably housed populations concluded that an excellent way to reach out to and further engage this population of pet owners may be through incorporating pet services such as veterinary care within existing human services infrastructure. We tried to follow these suggestions in offering vet care services on site in an OCH building. We believe that by acknowledging the strength of the relationship between these people and their pets, vet outreach may be a highly effective tool to engage this population in health service utilization, such as smoking cessation and reduction services. So, given that pet ownership contributes to human health in highly meaningful ways, such as decreased loneliness, depression, stress, and anxiety, and that this effect can be even more pronounced in homeless and vulnerably housed pet owners, it is fair to argue that informing these individuals of the harms their smoking may have on their pet could act as a strong incentive to reduce or quit smoking for the sake of their pet. Only one study was found that put forth such an argument and reported that a significantly large number of pet owners in the study stated that information on the dangers of pet exposure to secondhand smoke would motivate them to think about quitting smoking, to try quitting, or to prohibit smoking in their home. To come back and touch briefly on the planning and delivery aspects of the veterinary clinic and smoking cessation workshop, the project was agreed upon by all community partner organizations as an opportunity to create and strengthen community partnerships between the organizations involved, trial veterinary outreach as an engagement tool to see how it works and what is involved in carrying out such a project, and to build a more structured protocol and methodology for future research and publication. The project involved informing and recruiting participants for both the veterinary clinic and the smoking cessation workshop, with planning for each event taking place once the rough number of participants for each event was known. To conclude, this pilot project sought to address specific barriers to successful smoking cessation in a low-income population using a unique engagement tool. Given the overall success of the project and the partnerships between community organizations that were built and strengthened, it is hoped that in the future a successful research project can be carried out with all community partners once more involved. It is especially important to note the often undervalued importance of animal health and the human-animal relationship in the context of public health. Animals may provide an extremely useful method to reach out to and engage those facing inequities such as low income and unstable housing by first addressing the health of their pet. By incorporating pet-friendly environments where health and other community resources are also offered, and by acknowledging the important role a pet fulfills in the life of a person who is unstably housed, it is possible to make community resources and programs accessible and utilized by this population. I would like to take a moment to acknowledge the following individuals and organizations. Please note that a full list of references can be found in the accompanying Culminating report. I would like to take a few minutes now to answer questions.
So Kathleen, let me just ask, can you hear me through the mic?
I can. It's a little echoey, so I may have to repeat, but I can make out what you're saying right now.
Okay, because we tried with the last time to get people to come up and speak to the speakerphone, and it didn't work very well. So let's see if this works. Questions for Kathleen. This was another really cool project, gotta say. Every pet owner in the room is going, oh, yes, right? So who wants to ask the first question? Nope.
Hi, Kathleen. Can you hear me okay?
Yeah.
Okay. Thanks for your presentation. It was awesome, and congratulations on your little one. I was just wondering, specifically with regard to your project, maybe your thoughts on how you balance promoting an anti-tobacco message with not vilifying individuals who use tobacco.
Okay, great question. We worked with a lot of different organizations on this project, and one of the main players was Community Veterinary Outreach, and we actually created, one of the great strengths that came out of this project was we created a workshop for all of the volunteers with CVO titled a One Health Workshop that moving forward will be reused, where we did a bunch of training around very empowering positive communication techniques and a concept of communication called motivational interviewing. We touched on it. It's a really, really great communication technique, and it can be like a month of training to actually perfect the technique. But we did go through a rudimentary training on using that to communicate effectively and without kind of vilifying or victimizing or making anyone uncomfortable when addressing the topic of smoking with this population. The other thing that we tried to get across to the volunteers was also that though we initially think that people will be really unreceptive to talking about their smoking or having it brought up, the research actually shows that they're happy to talk about it. Most people already know that smoking is bad for them, and in this population specifically, one of the main barriers to successfully quitting smoking is that we don't bring it up enough. They possess a desire to quit, but because we often practitioners, etc., working in public health and in more like primary health care, think that, well, they have enough on their plate, we'll let them have the smoking because they're dealing with so much other issues as it is. And that's actually not the case at all. They do possess a desire to quit. They just aren't offered the window of opportunity to talk about it and the advice to quit and the assistance and programs to quit. So that's kind of what our project was trying to make it more accessible for this population.
Hi, Kathleen. I just want to say, first of all, that was just a great presentation and such a cool project I think that you were a part of. And I'm just wondering if you've considered approaching any like nonprofit organizations in BC or specifically in Victoria with some of like the research that you did for this and the presentation itself to see if they might be interested in incorporating an approach like this into the work they do.
That's a great idea. I haven't thought about it at the time. Actually, the way my presentation was structured, I created it in advance of the actual event where we held the veterinary outreach clinic in the building because I was worried about my own timeline. And after the event occurred, I actually went into labor the same day we held the veterinary clinic. So I would love to move forward with the project, and we would. There have been subsequent meetings, and I have been approached by my supervisor my practicum supervisor to continue working on this project with my agency, among other things, moving forward, especially with creating, like this was a pilot project. We wanted to see how it worked, if if our organizations worked well together, and we would love to get a more formal research methodology put together and actually publish on it. Like I said, this was just a pilot project, but at that point, it would be great to approach other nonprofits across Canada and try to move forward with this because it really is an under-acknowledged area of public health that we can really tap into, I would say. Now, CVO, Community Veterinary Outreach, was founded by a veterinarian in Ottawa, Dr. Michelle Lem, and there are other chapters of it opening across Ontario that she does kind of oversee, and so it is growing. And what CVO does is they partner with different agencies, clinics like this or workshops, or I shouldn't even say workshops, I should say veterinary clinics, outreach clinics, have been happening in Toronto, in Waterloo, Kitchener, where they have been partnering with different, even with Toronto Public Health, where they do flu shots instead of smoking cessation, where they do oral and dental hygiene, an opportunity to access that and for screening for oral and dental issues and cancers. And so the opportunities to use the veterinary clinic as a platform and then offer other important health services are really endless. And so it is something that I would definitely keep in mind. I'm just kind of, all my time is currently being taken up by a very, very tiny person. And it's very surprising, in fact. But moving forward, it's definitely something to keep in mind.
Hi, Kathleen. It's Michael Hayes here. I was going to ask a question, but you've kind of answered it. So I just wanted to say two quick things by way of comment. First, I think what you've done brings a new understanding of the phrase just-in-time delivery. But perhaps on a more serious or not less so serious note, you know, it seems to me that what you have presented, and to a certain degree, I think also what Solomon presented, represent kind of new ways of thinking outside the box around trying to reach populations that historically have been difficult to reach, leading, as you point out in your presentation, to the unintended consequence of actually increasing health disparities among groups within society. And the notion of trying to find different kinds of non-traditional ways, intersections between two important kinds of ideas, for example, cigarette or smoking cessation and the love of animals as a way of trying to deliver a message, I think is really very, very interesting and has parallels with Solomon's presentation about trying to find non-clinical staff within a health authority to help reinforce the message of cigarette, non-smoking, particularly on healthcare sites. And I guess by way of two things. One, I just want to acknowledge how innovative I think that is. And two, I just want to underscore how important it is to stand up to regulations, bylaws, or whatever, because if you enact something that says you can't smoke in a place and people ignore it, it is useless in trying to create change. I think of all of this non-smoking sites that, I mean, nominally UVic campus is a non-smoking place, and yet one of my students in the Social Dimensions of Health program has done a photo essay of all the cigarette butts around campus, which clearly show that it's a useless intervention. I mean, saying something doesn't make it work. So I do want to commend you and Solomon on these sort of innovative ways of trying to create intersections or new innovations to actually enforce that which was enacted to help to protect the public in ways that aren't punitive or disparaging of individuals, but are supportive of our collective rights to breathe air that is clean and not polluted by smoke. I'll stop the homily there.
Thank you.
That's great. Thank you. And I'm pretty sure that's Dr. Hayes talking, right?
Yeah, that was Michael Hayes, and I apologize to everyone for the bad pun.
That's a great comment. I want to add to it. For me, one of the things that stood out was how we have this whole other body of professionals among veterinarians that have this untapped potential to try to, advocate for change, not only on the behalf of pets or using the pets to reach out to and engage the owners and motivate healthy behavior change, which I had never thought of, this entire other body that we could partner with to encourage healthier and build and work towards a healthier population.
Great. Well, on behalf of the group, I'll again ask everybody to give Kathleen a little wave. And thank you very much, Kathleen. Carmel is now going, we're going to say goodbye to you. I wish you at least 6 hours of sleep each night. Good luck.
Oh, that would be so nice. Thank you. Fingers crossed for me. Take care, everyone. And again, I'm so sorry I can't join you. I've been watching the webcast. It's fabulous. Great presentations. Such creative ideas. And it's so exciting to see everything that's being accomplished. And the best of luck to all of you. And if everything works out, I'm hoping potentially I'll be able to attend Convocation in November. So hopefully I'll see you all then. Take care.
Bye, Kathleen.